I didn't see the button. There we go. Perfect. All right. Yes. Welcome everyone to another Monday VMR. Thanks so much for coming and excited for the case. It's been a little while since I've been able to discuss, and we have an all-star crew today. So obviously discussing with Alec, my partner in crime, but then we have Simi and Anmal doing the scribing and teaching points respectively, and then Vinny is going to present a case, which means that I'll have to dust off the cobwebs very quickly. Um, but yeah, if Simi and Amal, you want to just give a hello, then we can go ahead and get started.
Hello everyone, just excited for Winnie's case and ALA session. Looking forward.
Hello everyone, my name is Anmol Preet. Very excited for today's session. Thankfully, I was thinking about going to grocery and now I know that I'll be typing the teaching points before that. So very excited for the session.
Yeah, so hey everybody, I'm Vinny. For those who don't know me, I'm a final year medical student, and I'm super excited to present another case. And we can start. All right. So just to give you a little bit of context of this case, imagine that you're discussing the case during rounds. It's everybody in the room, the senior resident, the junior resident, the medical student, and then you're just discussing the case of this patient, and you receive a MAT call, so the acute emergency, medical emergency call, and they ask you to go to see the patient because he's feeling short of breath. And then the junior resident go see the patient. I mean, while like the rest of the team is reviewing the records and the history. So we'll give you the context right now, and then we'll move to the bathroom. Okay. So here we have a 80-year-old patient, male patient, that has that the chief complaint for his admission in the hospital is a worsening whole body rash with mucosal involvement, and 7 months ago, the patient experienced worsening psoriasis on the dorsal aspects of both feet following his immunotherapy for cancer and for lung cancer. And then I will give you the past medical history, the complete past medical history. And they believe that the worsening of the psoriasis was related to the start of the immunotherapy. Then his oncologist just decided to stop the immunotherapy. So in December of 2024, so let's put like that. So 4 months ago, 4 months ago, he developed a pulmonary embolism and was starting on apixaban, and he was doing well. He was doing fine. There was an improvement of psoriasis and no other symptoms regards the worsening of the PE. And then 3 weeks ago, he just noticed the spreading of red macular lesions, erythema with skin, and just like 2 or 3 ulcers in the roof of her mouth. And but the lesions started in the legs, bilaterally, and then spread upwards up to the torso and the medial mucosa. So I'll just stop here, okay? But let me see if the history makes sense. I'm trying to put the things together.
Yeah, great. And then just to clarify, Vinny, so so 3 weeks ago the rash started, and then the patient presented for admission for this rash, and then Is this like day one of hospitalization when you guys are discussing the patient and you get a call that he's experiencing shortness of breath?
Yeah, it's the morning. Like he was admitted in the evening, the day before, and this is the morning.
Got you. Okay, so overnight, you were kind of discussing this new admission getting
Yeah.
signed out, maybe from the overnight team. And then unfortunately, you get a call that the patient's experiencing shortness of breath. Okay. Okay, very nice. Alec, any other clarifying questions? Otherwise, I think I'm going to let you handle the first part here because this is kind of your wheelhouse. Maybe you even experienced this earlier today.
Oh my gosh. I don't know if this is my wheelhouse, but what an interesting case, Vinny. You always bring the most hectic cases that really challenge us, so I appreciate that. So I guess I'll just try to summarize. So this is a 78-year-old gentleman. We don't have the full background. It sounds like he had a history of lung cancer, who was on immunotherapy, which he got 7 months or so ago and had a reaction, a dermatologic reaction, seemingly from psoriasis in his feet. Unclear to me if he had a preceding history of psoriasis and it worsened, or if they thought it was just related to the immunotherapy. And then 4 months ago, had a pulmonary embolism, and then 3 weeks ago started developing some rash of sort of macular lesions, maybe sort of less consistent with psoriasis based off the description, but hard to know. That began on the legs and sort of just tracks its way superiorly all the way up into the oral mucosa, for which he presented. And then following presentation, sort of hyperacutely, sounds like developed dyspnea. And so those are a lot of things we'll have to track. So this is an attempt to piece together, and I think it's really tempting to try and, figure out what can explain one thing or just one or two things that could explain all the symptoms. And I think at this time, we don't know the full complexity of the background or even the foreground. So I think it's, for me, hard to know exactly what to tackle. So how the immunotherapy plays in, I think we could hypothesize a lot of ways in which it could. But I think, for me to really get further clarity on that, I would just kind of want to look at the rash, and then think about, like, if the last time he got immunotherapy was 7 months ago, how much of this is really related now? And certainly it could be, certainly it would be, interesting to think about that. And Austin, my audio, you can't hear me at all, or is it?
No, I can hear you. I can hear you. It's just a little bit, I think we're getting a lot of kind of like background when you're talking, but it's okay. We can hear you fine.
Okay, sorry about that. So yeah, so I guess the PEM's just starting out for now. It seems like he's on appropriate therapy. So I think what I'm really going to tackle is this rash. That's the reason he came in. So 3 weeks of progressive rash with mucosal involvement. Certainly, I would be thinking about infections, potentially in immunocompromised host, whether that would be viral lesions that could be leading into that, whether that would be reactive after mycoplasma or something like that, or whether this could be autoimmune in nature, either primary or secondary to his malignancy. And I think really I would just be thinking about, like, what are the hemodynamics of the patient, like how much mucosal and skin involvement is there, and then alarm features, like is the patient very tachycardic, are they febrile, and sort of just make progress by looking at the rash and looking at the severity of the illness, and then sort of taking things from there. I think sort of just hypothesizing on what it could be would just be too broad, but I think I would just keep the categories broad and actually take a look at the rash and decide what to do from there. And then until I get more context of the shortness of breath, I think there's lots of pathways we could go down. If it's really hyperacute, I think sort of defining is the patient hypoxemic? Are they not? How the past medical history plays into that, and thinking about whether this is a oxygenation problem, this is a problem with carbon dioxide, whether too much or too little, and then whether the patient could be quantitatively or qualitatively anemic, and then also like if there's just an increase in the left atrial pressure from different things, and just lots of ways to build around it. So in short, this is a really rich past medical history of which we don't have a lot of clarity, but the rash, I think I would just want to look at it, really assess the sort of nature of the mucosal and systemic involvement, and then also assess for alarm features like fever or hemodynamic compromise to build upon further. And I think just a lot of the figuring out what's going on is going to lie in the past medical history. More about the cancer, is it metastatic or not, what therapy the patient is currently on, what they've received previously, and then kind of taking things from there. But also I'd love for you to layer upon that.
All right, amazing.
All right. Yeah, no, let me talk real quick, Vinny. But
Yeah.
I'll keep it brief, I promise. Sorry, I couldn't find my unmute button. But yeah, no, I think Alex talking about sort of how prominent the past medical history or the background is, and we're just trying to gain clarity in understanding what's happening so that we can best approach the patient in their sort of acute presentation now. Though I think oftentimes you don't have the luxury of having a full rich history and background, especially when you are sort of the admitting team or getting handoff overnight. You just have to go see the patient with really no understanding. This is where kind of what we do practicing in this space is really important because you can get a sense of having a framework to approach things. And then once you kind of get the process started, you can give yourself a little bit of time to say, hey, let me understand the patient more in order to make progress. But I think just things that stood out to me beyond what Alec already mentioned was, psoriasis, again, as you mentioned, will be interesting to know if this is a history or this is a manifestation of sort of a dermatologic or cutaneous IRAE, as they call it, or immunotherapy related adverse event. And it'd be a bit odd to have psoriasis like isolated to the feet, I would say. So I'm just sort of, questioning that aspect of the diagnosis. But again, I think Vinny will clarify more about exactly what's happening. The PE, it's hard to put too much stock into that right now, just given the patient's background that you already know about them. And so I won't invest a lot into that right now. I'd say the time course of the rash is curious. Whenever I think about diffuse rash with mucocutaneous involvement, it automatically sort of my no misdiagnosis is like, does the person have SJS or TEN? It seems like it's pretty significant distribution, so probably be in the toxic epidermal necrolysis. But I think what is counter to that is the time course. I haven't seen a lot of cases of this, but in the few that I have, usually it wouldn't present on the order of like weeks and the patient like be well enough to remain outside of the hospital until now. And so I'm happy to be humble by that because my illness script is not particularly strong, but I think it seems a little bit long. And so if I think about, okay, what else can be affect the mucosa and cause something like this? And the only thing that really comes to mind to start, and I'm sure the differential is quite broad, but I'm sure that there could be immunotherapy related adverse events that could span the spectrum. But in particular, if you think about IREs and not only their predisposition to infection, which is less so than other type of chemotherapy, for example, but maybe the patient receives something else in conjunction with immunotherapy. But the other thing would be like pemphigus, because it can involve the mucosa, not only of the skin, but the lungs themselves are a mucosal surface. So trying to connect those two things together, I think is a bit premature to start. You wouldn't go in the room and be like, oh, this person's got pemphigus, let me just like pulse steroids and see what happens. But I think it's curious enough that I'd really be filtering the time course with this diffuse skin presentation, understanding that I don't want to miss the most morbid thing of TEN, but at the same time, the time course seems slightly incongruent with that, at least with my illness script. So that would be something I'd be looking up in real time. So yeah, Vinny, excited to learn more from you.
Yeah, well, outstanding thoughts just for the first avocado, and I really appreciate it. So 3 days ago, he like started with the deterioration and increasing of the rash, and like the medical team, he followed closely with his oncologist and like had good access to health. And then the dermatology was consulted on that time, like 3 days ago, and they did a biopsy of the lesion. And the diagnosis of the biopsy was chronic interface dermatitis with hyperkeratosis and spongiosis, and was more than they related that in the results with a drug eruption. And then we started to think about what kind of drug he started in the previous like weeks, and there was but none. But in the previous months, there was some changes in the anticoagulation. Just remembering that the PE was exactly 6 months ago. But anyways, and then when he had the chronic interface dermatitis, he was started on prednisone 40 and topical triamcinolone. And he at the same time, like multiple medications that he was taking was recommended to be stopped by dermatology. So I will give you the list of what was recommended to be stopped. So allopurinol, colchicine, tamsulosin, Eliquis, and Bactrim. So he went to the ED again to see why things were not improving, because he stopped at those medications, and they went to an outside hospital, and in the outside hospital they thought about cellulitis, and they did solumadrol there, and uh, and then he was he was transitioned into our hospital. So just to give you a little bit more of the past medical history, as I said, he has lung cancer with brain metastasis, and he was initially started on carbo and pan chemotherapy, and stopped it due to pleural effusion, and then he was transitioned to nivolumab and stopped it due to psoriasis progression. And regards to psoriasis and long-standing history, he used Stelara, that is, for what I remember, ustekinumab. I don't know if this is the correct name, but that's for 4 years ago he was in that. And I don't, unfortunately, I don't have the last dose of this medication. And other than that, he has diabetes, hypertension on hemipril and Coreg, peripheral neuropathy on gabapentin, BPH, HFpEF with a ejection fraction of 36 and on Crevedilol, and coronary artery disease with 4 stents placed more than 20 years ago. Yeah. And also COPD, use incorrectly inhalers daily. He uses over the counter inhalers, and that's another thing. When while you're reviewing the chart, you just receive a call of the junior resident that went to see the patient, and for what he can get, so like in 2 or 3 minutes of history, is that yesterday he was like using abusively his home inhalers, and it was not improving, and then had the shortness of breath. And also in this morning, like 1 hour ago, the the start of the severe shortness of breath, he took pentamidine due to the steroids, because he was on steroids. So, and he was using Bactrim and pentamidine for the BJP prophylaxis. I'll stop here, okay?
Wow, okay. Yes, no, thank you so much. Rich history. Alec, I guess I'll maybe peruse the medications, and then I'll leave maybe the past medical history to you, and then we can try to make some progress from there and just go back and forth. If that sounds all right. Okay. So I think as Vinny is guiding us here, whenever we see a patient with a diffuse rash, it usually implies it will be if you think about, is this an inside problem or an outside problem? And that's one way to approach a rash. The more diffuse the picture is, the less likely it is to be a topical problem, like a focal problem. And so this suggests that this is a more of a systemic cause of why the patient has developed a rash, as opposed to a sort of local reaction. There are some caveats to that, but generally speaking, that holds well. And so in this particular case, what can go everywhere, and often it is, it could be like molecules in the body, like we could think about someone experiencing anaphylaxis, but from a standpoint, statistical standpoint, most commonly people come into the clinic or their outpatient doctors initially. This is going to be some sort of exposure they have, and usually it's idiopathic, or not idiopathic, but iatrogenic, in the form of medications that we give to the patient. And so carefully and appropriately, they review the medication list and discovered a few things that stood out. So allopurinol famously can cause SJSTEN, in particular in certain people with certain ethnic backgrounds and certain genetic mutations. But I think it's very reasonable to stop the medication for that. Tamsulosin, there might be a bit of a knowledge gap for me, but I don't typically associate that one with prominent cutaneous manifestations, though I'm sure if you look up online, like if you use Visual DX or something like that, or go on UpToDate, like there's probably case reports and stuff, but that's not one I commonly associate. Eliquis, neither. I don't associate that one. Bactrim certainly can. Colchicine can definitely affect mucosal surfaces, so that's something to consider. And then these weren't really like ones that Vinny explicitly mentioned, but steroids and pentamidine. Pentamidine, I don't, typically it's like inhaled pentamidine, so usually you wouldn't get a systemic response to that necessarily, but that's not one I have a common association with. I think the other thing to think about is this steroid inhaler. And Vinny, was this in the United States or was this in Brazil?
This was in United States, and
United
just
States.
sorry to interrupt, but like the one super important thing that I missed is that when he had worsening rash, the dermatologist discussed it and suggested to improve the PRED for 40 to 60, and he didn't went up like a couple weeks or 3 weeks ago. Sorry to interrupt. Please go on.
No, please, thank you. So he increased the prednisone to 60 milligrams. He's been taking that for like 3 weeks.
No, he didn't.
Oh, he did not. He did not. Gotcha.
Yeah.
Okay.
Mhm.
Understood. Okay. So, yeah, and this is a good transition to a point as well to make, is that, there are drug reactions that can happen within days of taking medications. But usually the more diffuse ones, or the most severe ones, like SJSTEN, for example, or DISH or DRESS, those usually take some amount of time to develop. So you get a drug, you get exposure that's usually on the order of weeks before that you were exposed to, and then you develop the manifestations. Unlike if you develop like a morbilliform rash, or if you develop anaphylaxis, like those are usually more acute. So these types of rash that we're invoking, like usually suggest that there was exposure maybe weeks ago, as opposed to more acutely. And so that's something that I always forget as far as understanding the time course, because you could review a patient's med list and be like, oh, you just started this medication. This must be the cause. But most of the time, these types of rashes take time to develop, and the immune system to sort of prime a response. And so you have to understand the time course of the medications to see if they could be culprits. In this particular case, it seems like the patient had been taking these for various reasons and for probably some period of time. So any of them could potentially be culprits. So since this is in the United States, finally just going to the inhaler, the only over-the-counter inhaler that I know that you can purchase is epinephrine containing. And so I don't really associate that with anything terribly bad. But I haven't been in the space where someone's been using it to excess potentially. But I imagine that the side effects would be pretty similar to any other sort of catecholamine excess potentially. And so I think that's probably the approach that I would go down, and maybe I would layer that into, or how the patient was using the inhaler, or if we didn't hear about a smoking or vaping or history or anything like that, but that'll be interesting to know. But a sort of a rich drug history, understanding which ones cause what disease and what time course they do it in is helpful. But I think in this particular case, because we have a diffuse process going on that's widespread, that really suggests that drugs could be a culprit, or some other systemic process. So with that background, Alec, what do you have to add? And then you can lean in on the history a bit more.
No, thanks so much, Austin. And Vinny, just to clarify, what type of lung cancer does he have? Do you know? Did he have adenocarcinoma or a small cell, or?
Oh, I don't have the specific type here. Sorry.
No, that's okay. And then as far as the steroid time course, so it sounds like they had recommended he go up to 60 milligrams of prednisone, but he stayed at 40 milligrams. How long has
Yeah,
he been on 40 milligrams of steroids?
it's been 3 weeks.
3 weeks. And he wasn't taking any steroids before that?
No.
Okay. No, thanks so much for clarifying. Yeah, so I mean, I think on the past medical history, Austin already sort of summarized the medications really nicely. Some potential offenders like the allopurinol, the colchicine, and the Bactrim in particular. The Pixaban and the tamsulosin are sort of less culprit, at least in my experience. The cancer therapy, he's been on multiple different therapies, and then was also on ustekinumab or Stelara, which could further immunosuppress him. But the time course at which he received that is a little bit unclear. But it's good to know that the psoriasis was a preceding diagnosis. And I think layering his past medical histories, he has numerous cardiovascular risk factors. He's got diabetes, he has hypertension, he has coronary artery disease, he has, probably ischemic heart failure, and, also has, I imagine he has a pretty extensive smoking history with his COPD, but I guess that would be good to clarify if it was non-tobacco related. But certainly, in acute shortness of breath and that many cardiovascular risk factors, we wouldn't want to miss pulmonary edema or something like that. But, how to incorporate that into the moment, I think is a little bit difficult. But it seems like in the limited information we do have about when going to the bedside that the patient has been more dyspneic, at least for a day, and has been using his inhalers very regularly, and unfortunately hasn't been helpful. And I feel like I see this not infrequently in my patients. They feel short of breath, and that could be for many different reasons. But the first go-to thing is to go for the inhaler, even though the underlying driver of the dyspnea may not actually, be from bronchoconstriction. And so I'm not sure if that's a clue that of the severity of like a COPD exacerbation per se, or if it's actually not related to that at all. And then, yeah, as far as the inhaler is concerned, at least where, I practice, it's not uncommon that, patients get like prescription medications from like a friend or like a local, pharmacy that's more related to like maybe their country of origin and whatnot. So it's really hard to know exactly what he was taking, but I would love to know that. And then the fact that he was on chronic steroids, for 3 weeks, certainly could increase his risk to obtain an infection. Although 3 weeks isn't always the amount of time that we would recommend PJP prophylaxis, for example. It is something that we need to consider. And could that cause acute shortness of breath? Certainly. And I guess I would love to know the frequency of which he was taking the pentamidine, and also like how long ago he stopped the Bactrim, because it seems like he probably stopped the Bactrim around the time he took the steroids, so that he hasn't actually been on any Bactrim. So to think about how PJP could play into that. But extra pulmonary features of pneumocystis would be fairly uncommon. So I think at this time, there's a lot to layer in here, but I really just want to go to the bedside and see this patient. It seems like he's in respiratory extremis, and the rash and the mucosal involvement and all these other things are extremely important, but protecting his airway becomes first and foremost. So I think really getting an assessment of like what is driving his dyspnea, because sometimes we need to treat before we diagnose. And I feel like I'm getting the sense that he's pretty sick and we're going to need to investigate that further. And then we could dive into some of this a little bit afterwards. But, I think those were kind of my initial thoughts, Austin. A lot of ways to take this, but a very rich history. And certainly we could talk about all the different ways that each one could play into another. But I think at this point, I just need to put my hands on the patient and try to figure out what the real pivot point is going to be. What do you think?
Sounds great. Let's hear more.
Yeah, absolutely. So just to clarify regards your question, he is the first time that he took the pentamidine this morning, and he was taking the Bactrim since they was considered they considered to start the prednisone, because the patient has a huge history of atopy, and also had the dermatological manifestations throughout life, and very difficult to control the psoriasis, and due to this history, I am not 100% sure that's the main reason, but for what is described is due to the history of atopy and of the severe reactions they started all the coaxes. So anyways, then you go to see the patient. Okay, and let me give you the physical exam. So his blood pressure is 140/70. He's tachycardic 110. His temperature is normal. Respiratory rate is 26, and normal BMI, and he is saturating 91 on room air. And what is pertinent in the physical exam is in distress. In the lungs, there's diffuse wheezing all throughout the lung, and normal cardiac examination. And in the skin, I will ask Sini to show the picture, but it is described as diffuse confluent macular erythema with red lesions over the torso, arms, and bilateral dorsum of feet with scaling and tenderness. There's also small pinpoint ulcers in roof of mouth. So this is illustrative pictures. It's not of the real patient pictures. I'm sorry that I didn't have them. And also regards labs, the regards CMP and CBC, the unique pertinent finding is a leukocytosis of 18,000 with neutrophilic predominance. But let's remember that the patient already had leukocytosis prior hospitalization, and when everything started, he had also the leukocytosis secondary to steroids. So yeah, and then you're in the room, you're discussing with your resident what he thinks. You're already started the patient on BiPAP. He starts to improve in a little bit. Is the saturation improved right now, and but he still feel distressed, and he's very red, like all throughout the body. He's red. I'll stop here.
Okay, wow. That's sort of getting a good picture of the patient at the bedside. Thanks so much, Vinny. Lots going on. So, also I'll try and take some of the physical exam, and you see a lot more rashes than I do. So maybe I'll have you lean into that as well. But basically, the patient is quite tachycardic, 110. He's tachypnic. He is mildly hypoxic, but his work of breathing is what's really concerning to me. And I guess I would love to know what the patient's mentation was like, or if they had any edema or JVD, just as a sort of other context clues to other things that could cause acute dyspnea. But the wheezing in a history of atopy would certainly be concerning for bronchoconstriction. And I think in that situation, there are other things besides reactive airway disease that can cause wheezing, like pulmonary edema, for example. But we're not getting the flavor of that. So I guess I would be wondering what's triggering this. Is there something that's triggering his underlying reactive airway disease, or is this wheezing from something else, like an infection from, sort of paraneoplastic eosinophilia, or a parasitic infection, or something else that could be going on, or whether or not this wheezing is actually in his upper airway instead of his lower airway, right? Because you really wouldn't want to miss anaphylaxis, or you wouldn't want to miss stridor, or if you could have a mass or something in his larynx, right? Or his pharynx. So I think I'd be wondering if the wheezing is more expiratory or inspiratory. And then, in addition to listening to his lungs, listening up to his neck and examining it to see, what else could be going on there. And the rash is really striking. It's hard for me to get a good picture, but it seems to be involved in pretty much his entire body, and it's almost just sort of diffusely red. So I'd almost just translate that into erythroderma, which for people that have psoriasis, at least it's my understanding, if you give them steroids, there is some evidence to say that maybe you can precipitate crisis, so you would sometimes avoid it. But I don't think the literature is like purely definitive in that, but at least that's my experience. But then there are lots of other things besides that can cause erythroderma, and that would just be something that I would be considering. But Austin, I think those are my initial thoughts on the lab and his clinical presentation. So I think I would be really worried about securing his airway. The BiPAP, I think if he's hypercapnic, I think that's a great tool to go for. And just trying, if he has such wheezing, I would be really considering giving him a lot of nebulizers to see if we can open up his airways a little bit. Trying to be sure he doesn't have anything in his upper airway and doesn't have anaphylaxis, for which we would need to give him epinephrine or something. And then trying to figure out, is he tiring out? Do we actually need to intubate him? But there would be some, significant concerns of that. But whether or not we'd be thinking more about sort of acute respiratory management, sort of steroids and nebulizers, potentially antibiotics, and then, really trying to stabilize that, getting a blood gas, and sort of making our interpretations from there. But also, I'd love to know how you're interpreting the vitals and the physical exam, particularly the rash, and how you're layering in the labs.
Yeah, no, really nothing to add to your excellent analysis besides just as you said. I think the possibility of erythroderma looms large, especially in a patient with the history of psoriasis and steroid exposure. Though again, I agree that when I've looked this up before, that the risk is pretty low, just as the risk with like giving steroids and precipitating a scleroderma renal crisis in patients with scleroderma, like probably it's way overblown. So nonetheless, I think I'm not familiar enough with this to know like if that could fit with the time course, because I'm really struck by that. Is it just the patient's relative immunocompromise or like frank immunocompromise that is affecting the time course of the presentation, or is that a clue to the diagnosis? And so I think that's something I would just have to do a lot of research on in real time. But I guess, Alec, I'll pose another question to you. You see a patient that has a long smoking history, carries a diagnosis of COPD, not on any inhalers, basically has prominent shortness of breath with wheezing, um, could suggest COPD exacerbation, I suppose. But what do you make of the patient being on steroids, in a pretty good dose of steroids, 40 milligrams, this entire time, and how you think that influences the patient's presentation and the differential diagnosis, if at all?
Yeah, that's a great question, Austin. And I think the BMI was normal. I guess I would be wondering if it's on the higher end. Sometimes people might just need a little bit more. Or, certainly there's phenotypes of reactive airway disease that are so eosinophilic predominant that even steroids aren't enough. And you have to use, anti-IL-5 therapy. I've seen that more in asthma, for example, but there are sort of COPD overlap types. But I'm not even sure like how the diagnosis with COPD was made. Does the patient actually have like atopic asthma? And, the eosinophils are masked right now because he's on steroids, but maybe he's actually had EGPA this whole time. Or maybe he has, a mimic of asthma per se. So I think getting additional history on that. So, the idea that he's having a breakthrough reactive airway disease exacerbation through steroids is an amazing point. I guess I wonder if he would just fall in the category of perhaps his disease is more eosinophilic, or he has another trigger for which the steroids weren't able to overcome. And, whether that was more likely to be infectious or whatnot. So I think that would be something that I would be thinking about, but I'd love to know if you were thinking something different.
No. I think that's exactly right. It just sort of struck me that, the patients were receiving steroids for weeks, but despite that, it's progressively worsened. It sounds like there was some momentum to increase the dose of the steroids. And so is it just that we have a steroid responsive disease, but we have not reached the treatment, like the dose response threshold yet? Is it that the patient has an inflammatory disease that is not steroid responsive? Or is it that the patient has a sort of infectious inflammatory disease that maybe initially improved and that now are progressively worsening? But again, I guess beyond some of the more sort of indolent infections, it would be odd for this to be like staph or strep, and cause overwhelmingly diffuse rash and it be in a sort of subacute time course. And we haven't heard anything about fever yet, surprisingly. Again, I'm not sure that's if that could be a reflection of the patient's like immune status in and of itself or not. But yeah, I guess I'm just I'm also not certain if what are we trying to do we need to solve these in conjunction, or do we need to say, as you said before, like we're going to solve the dyspnea, we're going to work on that? Are these things related or not? Or is it? I think as you mentioned, it seems probably more likely to be a consequence of this hectic background than it is like a unifying diagnosis. But in this sort of sphere of the discussing unknown cases, like we try to link these things together. But I think in real life, as you already alluded to, like if a guy comes in 3 weeks of prednisone, maybe the compliance with medications is not exactly what I'd hope. I mean, this is PJP, the long still proven otherwise, though there doesn't seem to be prominent hypoxemia here necessarily. And then wheezing might be incongruent with that, though, if in the setting of potential, we have longstanding atopy, it sounds like, and then potentially a smoking history enough to cause COPD. That maybe we don't need to think too hard about that. But yeah, no, I'm sort of struggling to put all the pieces together in a way that makes sense to solve the right problem. And so I think in real life, if I'm being authentic, like I think we've all had this situation where I can remember being a resident and just being like, oh gosh, this patient's sick. Hey, let me just go see them. You guys finish on rounds. And I'll walk to the room or kind of look up the patient's chart or I have the H&P in front of me and I'll just read it. And then go in and evaluate, and then we can solve after that. And so I'm not sure I'd be pontificating too much about everything at this moment in time. Just trying to help the patient in the moment and then going from there. But excited to learn more from Vinny.
Yeah, well, amazing. So As I said, they started the BiPAP, and then the patient started to get better. So we are more calm now, and but he did not like resolve complete the clinical picture, and then the resident just decided, oh, so let's do epinephrine for him. It was done, the epinephrine. By this moment, I was questioning myself if this is an anaphylactic reaction. I don't know if this makes sense, because what triggered that? And there's nothing that triggered. And he took the like what kind of meds he took in the morning, and he took the pentamidine for the first time an hour ago, and then due to the thing that the patient is deteriorating or just not improving, um, they just decided to do the epinephrine, and let's discuss that after runs. So it was done, the epinephrine, and the BT revealed a pH from in like right after starting my PAP, seconds after. So the pH was 7.35, the PCO2 was 68, the PO2 was 70, and the bicarbonate was normal. So um, that was the mat. We just came back to the of the room, and during the afternoon, we started to look what can what can cause this, and then the other resident just came with the hypothesis of the pentamidine bronchospasm. It's a very well described situation, and or clinical thing. I didn't know that, so it was a new thing for me at that point. But so that was the resolution of the AMAT, and other than that, we are not we couldn't see what is the main clinical reason for the patient is like getting all the erythroderma and the skin reaction. Then, but then suddenly we discuss it again with dermatology. We hypothesize that this could be Steven Johnson's or TN and the other dermatologic reactions. They like they were very certain and reassuring that that was not Steven Johnson. And the unique thing that uh, rested was the the biopsy of the skin that revealed as I said previously, the dermatitis with spongiosis, hyperkeratosis, and that was secondary to the aliquots that was started when he had the PE. But then I am not sure if how can we discuss if this is indeed secondary to the aliquots or not even to the allopurinol or the other drugs that all the because the discussion at that point is that all this kind of medications were stopped, and so we are not we we don't know what is causing it. But due to the fact that the alcohol was started when he had the PE and he was already taking the other medications, so we hypothesized that it was more the culprit was the Eliquis. So yeah, that's the end of the case.
Wow, yes, thank you so much. And I think you are taking us to real life medicine where patients come in and, as we've advanced in our technology and understanding of disease and drug development, patients are living longer and longer. And this patient's almost reached their eighth decade of life and just see the number of comorbidities they've accumulated. And if you go back 50 years, there's no way this patient would have made it this long. And so when you start to admit patients to the hospital and they have this many problems, it becomes more and more challenging to really grasp the entirety of the situation. And I think this is where clinical reasoning is so important because there's so many ways to get bias in your clinical reasoning. If you frame this problem as say, hey, I have a a person with acute respiratory distress who received immunotherapy. Checkpoint inhibitor toxicity, right? And I've seen patients many times get steroids for that when in fact it is not that, but sometimes you don't know and you make that progress. Or you could say, hey, this is a person with acute respiratory stress and HFrEF with coronary artery disease, pulmonary edema, right? This is a person with lung cancer presenting with acute respiratory distress. Is this some sort of manifestation of their cancer? Did they have an effusion? Did they have a bleed? Did they have pneumonitis? Do they have um, like a mucus plug? Do they have an endobronchial lesion that's causing something? There's so many different ways to frame this and take this, but sometimes this is where just having a framework and being not entirely like you don't necessarily ignore the background entirely, but using it as a secondary point as opposed to your first pass analysis can be really helpful when it's easy to get bogged down in the details. And I think again, as you start to accumulate comorbidities, it's sort of like almost like a patient that has HIV. You say, hey, it's more likely there's going to be multiple processes going on as opposed to trying to link these together like pemphigus or any of the this a manifestation of a mucosal involvement of this patient's like skin disease. And so I think linking this, hey, this is the time course. Pentamidine definitely can cause acute respiratory reactions. I have seen that before, though it's not terribly common. And then on a person that was already on steroids, like I'm not sure how to link those things together, but again, it could just be that we couldn't overcome the inflammation in that moment. But yeah, really humbling case. Thank you for talking through it. I like how you sort of are trying to be really posit and figure out which drug is the culprit. I think ultimately you don't know until you restart the patient on the medications and see what happens, and I've been in that situation before, and you do your best and that's all you can do. It gets really complicated. But yeah, Alec, what final reflections do you have?
Yeah, thanks for your reflections, Austin. Vinny, thanks so much for sharing the case. Yeah, I think it's really, I think, frankly, impossible to say like which drug was most likely to have contributed. The effects from these medications, like even the immunotherapy, can lag for some time, and so it's hard to know which one is which. But you can only really make your best guess, and then, like Austin said, if you have to re-challenge, and I imagine at some point I'm not sure if the patient was indicated to have lifelong anticoagulation. I imagine the PE was probably revoked from the pulmonary embolism, and that wasn't going to get better. So, and I wonder what him and the team chose to do from there. But the pentamidine-induced bronchospasm isn't something that I knew about before, so that was great learning for me, and definitely think it could fit if he really did take it beforehand, and perhaps that was an astute observation from Austin that like maybe something that the steroids wouldn't really treat. I guess I was expecting I was thinking that the shortness of breath had begun before the pentamidine, but that was good to know that it was more triggered, and so that's something that I'll remember if I have a patient with pentamidine for next time. And then I think there's still a lot of questions like what caused the rash to begin with. Did the patient just have erythroderma the whole time? Like what change there was from getting the steroids in the rash, or the oral ulcers and the rash actually totally different things? Like, is it just because he was using an inhaled corticosteroid and not doing it properly and just got some oral ulcers from that, or just had some aphthous ulcers and the skin was completely unrelated? I think it's really, really hard to know. And like Austin said, like the more comorbidities you obtain and the more medications you're on, it just becomes more and more convoluted, and that's real life, and it's really hard to suss these things out. But I think it's just good as an example that this case is so easily to get overwhelmed from. Like you open up the chart, you see every past medical history known to mankind, and you're like, oh my gosh, how am I going to make my way through this? And sometimes just recognizing that like going to the bedside is the most important to be sure that the patient you're taking care of is doing well, and the chart will always be there waiting for you. So don't just get lost in that. So I appreciate you sharing the case, and I really appreciate everyone that has been helping out today with everything. So Steamy and Amal, thanks so much. And any reflections, Vinny, before we pass it on for the teaching points?
Just a brief reflection is that the main question for me was if the patient was started like on Alec was 6 months ago when he had the PE, why all of a sudden it started to getting worse, like getting worse, and like getting worse the skin lesions, it did not make sense for me at like first glance. So why all of a sudden in 3 weeks and was fast, not answering to steroids. But anyways, I don't think that we have an answer for that also. And it was indeed a really overwhelming case of seeing a such huge mathematical history and with the pressure to go to see the image. But anyways, everything working in the end. Please see me. And no, yeah, please, Enmo, take it away, please.
Thank you for the wonderful case and rich discussion. I think whenever we have such a rich history of present illness, it's important to see what are the important findings from the history so that we can dissect the differentials. So the patient came to us with the complaints of a rash. And if we talk about what can we think about the differentials of rash, what is important to know from the history and exam? We need to know what is the length of the rash and how much depth of the skin the rash is affecting. That can lead our differentials. And if the rash is blanching or non-blanching, we can put the glass test. We can see if the rash blanches with the pressure or not. And then what is the time course of the rash? These three things are very important to delineate the differential diagnosis. And then we can think about if the rash is due to an external issue or an internal issue. Generally, if we see a more diffuse rash, it indicates a systemic involvement rather than a local external reaction. So that was what we were thinking, that it was a diffuse reaction. So probably something going on internally that is affecting the body. The broad differential we had were infections, probably some viral infection, and can lead to the presentation of a rash. And in fact, the patient was an immunocompromised person, so the infections were higher up on the list. And then there are some autoimmune differentials as well that can lead to this possibility. But when we see such a diffuse presentation of a rash, it is important to get vital stat. Because if the patient is hemodynamically unstable, that is an alarm feature in the presence of rash. So what are the other alarm features? If the rash is painful or if it is spreading quickly, if the patient is unstable or is having fever. These are some of the alarm features to look out when the patient is coming with rash involvement. So if the patient is having a mucocutaneous involvement as well, then the no missed causes are SJS and TEN. But with these rashes, we expect a more hyperacute course. And the first thing we will want to rule out is drug reactions. And this patient had multiple drugs already he was taking. So that was one of the possibility. Allopurinol can lead to SJS, and pentamidine as well can lead to skin reactions. Other than that, I think in medicine, most of the things are just multifactorial. So there could be contributions from so many things that can lead to this presentation. So our other part of DDX also included immunotherapy, adverse effect, paraneoplastic pemphigus vulgaris, mucous membrane pemphigoid, vexus, Castleman's, paraproteinemia associated disorders, and IBD. Then we also saw that this patient was having shortness of breath. That could be related to the rash as well, because both of the presentations started acutely in the same manner. So, but if we want to dissect shortness of breath as a separate symptom, it can be issues with oxygenation, carbon dioxide, anemia. We can go over to the dyspnea pyramid to understand what was going on. So our broad DDX included, because of the presence of cardiovascular risk factors, we can think about something affecting the heart, or COPD exacerbation because of the history of COPD, and pneumocystis jirovecii. Pneumonia can also be a possibility secondary to in an immunocompromised host. And then we saw that the patient had a past medical history of psoriasis. It is important to know how it was diagnosed and if it's truly psoriasis, because sometimes some other diseases can mimic the rash of psoriasis and can lead to failure of treatment for psoriasis. So this is important to understand the past medical history, that if it is correct and how it was diagnosed. Similarly with COPD, how it was diagnosed and if it is truly COPD. And then we saw that the patient was having wheezes on examination. So it can represent so many things. Like if we say that the patient has come with rash and shortness of breath, it can represent anaphylaxis and can lead to the bronchoconstriction, which can present as in the form of wheeze. Then also COPD exacerbation can present like this. And even in the patients of heart failure, we can have a wheeze, which is not related to the lungs. It is basically a cardiac wheeze, which comes in the patients of heart failure. And then we discussed about erythroderma. Erythroderma is defined as a generalized redness and scaling involving more than 90% of body surface area, which can be life-threatening, and it can occur in the presence of pre-existing skin conditions like psoriasis, and even drug reactions can lead to this presentation. So I think ultimately the diagnosis was the drugs which led to the presentation, and it was a great case. It emphasizes the importance of going over the past medical history and the drugs to evaluate our diagnosis. Thank you very much.
Wow, thanks so much. And even added your own teaching points in there as well. And yeah, thanks so much to everyone and hope you all have a good day. We'll see you next time. Thanks you so much. Bye-bye.